So my name is Amaya Kulkarni, and I'm from the University of California in San Francisco. The study I'm going to talk to you about today is the Activate SF False Positive Registry, and it's a registry of about 400 patients evaluated in two emergency rooms in San Francisco who presented with a potential ST elevation MI. And in this study, we looked at the rate of false positives in this patient population. What we found is that the overall rate of false positive is about 36%. And in previous studies, we had examined the clinical and electrocardiographic factors that were associated with these false positives. And in this study, what we did is we tried to use those factors to create a score to improve our diagnostic accuracy. So whereas before we were getting a false positive rate of 36%, using 6 criteria, which include the history of coronary artery disease, drug use, and presence of typical chest pain, as well as Q waves on EKG, left ventricular hypertrophy, and reciprocal ST depressions. If you use these 6 criteria, you can improve your diagnostic yield for determining a true or false STEMI separate from EKGs. It has the potential to be very powerful in settings when timeliness is of an issue, such as in the activation process of an ST elevation MI. If a patient presents with a potential STEMI and it turns out to be a false positive, they could be exposed to extra radiation and the risk of an angiography, a procedure, and the fact that they are taken emergently also increases that risk. So it is not a riskless event to have a false positive activation.